So if you don't know what we do, we're not a very well-known body. There's about 500 of us. We sort of sit near the Department of Health and collect any data that flows nationally. We produce a series of publications, about 200 a year, of specific aspects of health and social care. And people have started to invent a number of frameworks to enable people to measure things more appropriately. So the NHS is very good at measuring inputs and things that happened. It's not very good at measuring what actually happened to people and whether interventions were beneficial. So a focus on outcome frameworks. Did you get better after your hip replacement, or did you not? And we've got some other minor roles which I won't touch on to. Because we handle patient identifiable data at the centre, we're quite, what's the right word, stringent on information governance, sometimes beyond that which you might think is necessary. But if we failed on that, our reputation would be toast and we'd cease to exist. I've touched on some of this already. The NHS is going through a big series of reforms. I wouldn't worry about them too much, except to say there's a whole series of national bodies being created, not least of which the NHS Commissioning Board, which will become separate from the Department of Health. We have a new information strategy, I think it's called the Power of Information. More importantly, we have in the Commissioning Board a new head of patients and information. There's a guy called Tim Kelsey, who's got an interesting background, and that he started life on the Insight team on the Sunday Times. He ran the Insight team, he's a journalist. He then founded Dr. Foster, which was the first organisation to take NHS data and attempt to make some sense of it and play it back to the community. And having met him 2 or 3 times in the last fortnight, he's a man with passion and in a hurry, which is really good for this whole agenda. So I mentioned the secondary user service. I've got a picture to describe that in a moment. We have some other tools, NHS comparators, which actually allow you to look at data across the GP practice and then roll it up into primary care trusts. That will need to change. And there's some other things coming down the track. I've mentioned the community data set. That's essentially about care that's delivered outside of an institution. And we've currently no knowledge about what happens when district nurses and health visitors turn up in people's houses, do stuff, but they burn about £10 billion a year. So that data set's pretty important. We've built a system with partners called the GP Extraction Service to allow us to fire queries at all the GP practice systems via their suppliers under stringent IG rules to bring data back into the centre with a view to linking it in a safe haven to some of these other data sets. We just recently, from this summer, started to take a diagnostic imaging data set from hospital radiology departments, primarily so that people tracking cancer pathways can make sure that people had an appropriate radiological investigation at the right time or not, as the case may be. So this one's a bit Mickey Mouse if you've worked in healthcare before, but crudely every time you turn up in hospital, surprise, surprise, people collect some demographic information about you. Much of the stuff that doctors collect is sadly written down in paper notes at the moment, unless you're in a very small proportion of the country. But certain things they have to do is they have to write down what they thought was wrong with you in terms of your diagnosis, and also any operations that were applied by the surgeons to you. And those are the only really 2 clinical bits of information that flow with that commissioning data set. And that's the basis on which the SUS data flows are based. I wouldn't dwell on those numbers other than to say there's around 4 million of these records entering SUS every day on average, and at a peak rate of about 8 million. If you know anything about how much activity happens in the health service, you realise that a lot of them are being sent 2, 3, 4. I think the average is probably about 8 times. Because this drives payment, 28 billion pounds worth, people keep refining the codes about individual diagnoses and operations so they can make the most money, as the pointless dwelling over the fact that's what they do. They game the system until the system shuts the door and says, thanks very much, we've had enough of that data now for that patient, I've had it 8 times. And BT religiously store all of this for us, hence creating a rather large data store, some of which will be worth transferring and some of which won't. Sorry if there's anybody from BT in the room, I'm just upset by saying that. It's not their fault, it's our design, our requirements. So fundamentally we want to change how we provide these types of services away from a big black box. We want to separate the data storage and processing from some common services that would allow a number of applications to plug into an overall ecosystem. And the bit that gets me out of bed in the morning is this bit, the applications that turn data into information. I would like dozens, if not hundreds, of these applications to be created by people such as yourselves to plug into this infrastructure to do something with the data that currently hasn't been done before. And I think the applications are potentially infinite. You could call it an app store for health. There'll be other people creating apps of a different type that are more transactional rather than this type, which is more about mining data and turning it into intelligence and insight. And we think if we do that, we'll be able to run this platform for less. In particular, if anybody has any new ideas that cause cost on the platform to go up, that they find a way of recouping that cost, including from their end users. So if you've got an application that you would like to make money out of on a subscription or some other basis, there's no reason why you shouldn't go through what we hope will be a lightweight accreditation process and plug into this platform. Pictorially, that describes pretty much what I was saying there. Every new data set that appears that's sort of ready to flow nationally or sub-nationally will be a sort of separate discrete project that will enable more stuff to be landed in the platform. And as I said, the information users could be infinite, and there should be an open market in that area. Technically, that's not a hugely easy slide to see. The colour coding is meant to differentiate things that we would do versus our partners in the private sector would do. This bit's particularly hard to read, being black on mode. We will change that bloody slide. Underneath there is the service integration and management layer, which some of you may say, oh yeah, that's government flavour of the month, that you have to have one of those. But it's basically a means of having oversight of all the different components and how they fit together, and to ensure that the platform runs smoothly. This in itself might end up drifting up into the authority space, us, light blue, or it might be a joint venture, or it might be an out-and-out private enterprise. I wouldn't worry too much about that at the moment. So again, I'm just going to run through these quite quickly. You might not be able to see all of that, but we are going to expect different data to arrive in different forms and sources. Some of it will be nicely wrapped up as XML. Some of it will take in whatever form it comes. We've used the term a data bucket to get away from the fact that is it a warehouse, is it a database, is it end databases. We don't care. We actually don't care if there's 2 or 3 different database types used in there. It actually doesn't matter. Obviously, pseudonymization and IG controls. So some of the common services that you might expect to see there. So obviously, an inventory that explains to people what's in there. There's an underlying data model that we expect everyone to conform to. Some audit and logging tools and so forth. So if I was an IC person and I was allowed to look at patient identifiable in the clear, I might plug into Spine authentication services using my smart card and authenticate myself as being allowed to do that. So a particular application that we've described as a mature service is something like the SUS PBR model, where there is a series of business rules applied to the data. I've glossed over the fact that data quality can be dealt with at an early level and fired back to the originator. And so an available service might, in the first instance, just be payment by results. One of our colleagues in the room in his spare time has written an application called Rate My GP.
GP rating.
Sorry?
GP rating.
I call it Rate My GP. I don't care what you call it. I call it Rate My GP. oddly enough, driven from a very worthy premise in that he thought his mum was getting poor service from his GP. Spookily, it's the same GP practice that my mum also attends, and he decided to collect some data from the public domain, as we're now pushing more data out, to enable people to look at what other people think of those GP practices, and look how far away they are and what services they provide and so forth. 69p, I think, from the App Store.
Yeah.
And grossly underpriced. If you're over 50 like me and actually start to worry about these things, I'd actually pay a little bit more. But you're a mate, so you'll give it to me for nothing, maybe. So that's an example of something where, you know, we might agree a price that the consumer might pay. It might be £1. He might get to keep 69p, and 31p might go into the running of the overall platform, or something similar. Or there might be a sponsor in the Department of Health that says, here's the money to cover this new application, which I think is really important. But we don't want to be reliant on that. And then that just extrapolates that sort of slightly ad nauseum and introduces, you know, rate my hospital. Dr. Foster might not like an application to be called something just like that, because that might be encroaching on their territory. But actually, people have already reacted to that sort of space. In the hospital I used to work at, University Hospital Birmingham, effectively started to offer what Dr. Foster did by taking our HES data and representing it alongside some national benchmark. So some of these things are already happening. So why are we here today? I think we've covered probably a couple of the first two. We want to test some ideas with you and get your feelings and thoughts about whether this is a worthwhile activity. We've got some problems that we want you to address. For those of you who don't know, a spell is not something that witches cast on you. A spell is a series of events that happen to you in a hospital under the care of different consultants. That matters ultimately for what people are paid, how people are paid. Data linkage is actually the clue to unlocking lots of value in this data. If you can track a patient's journey from what happened to them in general practice to what happened in hospital and what happened next, you can often better find out where things have gone wrong in the process and do something about it. Records that we don't know what to do with, and subject access requests. We currently, if a patient wants to know what's happened to them, there's a big background activity of churning through paper and giving them information. Obviously, if all the data on them is flowing through this, you might press a button and say, here's everything we know about you, we hope it's accurate, and then hold your breath. So we've created a platform as a service for you to hook into today. You may not have brought your own equipment. It's possible you could use an IC laptop if you want to, but I'm sort of expecting most people have brought their own, unless someone says to the contrary. And if you see anybody with a white T-shirt around, they're meant to be helpful. If they're not, you can complain to me at the end of the day. You won't lose the T-shirt. So they're available to help you get going, solve the problems. We've got effectively a simulation of a service integration management layer. I think we've decided to use Twitter as the service desk. Is that
no? We've got a formal service desk.
We've got a real service desk.
What we've been using Twitter for is if anyone's got any quick questions, ideas, bits of information that they want to share, or if they want to gain access to an expert around the data that they're working on. It's worked really well if you just put your name, desk number, and sort of information that you're after, and we'll be able to bring the appropriate people over to you.
Okay. That's probably too hard to see, but it might be worth leaving up on the board. You can tell I didn't come yesterday. It's just all rehearsed very carefully.
It was just as carefully yesterday.
Dreadful slapping. When it gets to 10 o'clock, there's actually going to be a fire alarm, so it is a test, so you don't have to race out the building. We've got some prizes to award. There will be a daily prize. I think it's an iPod Shuffle, unless somebody's upgraded it magically overnight.